There are many diseases that present as chest pain. The goals of this video are to provide you with a question-driven framework on which to base your differential diagnosis while allowing you to pursue an intuitive history and physical exam that actively rules diagnoses in and out. It is important to note that this video is not meant to be comprehensive. Rather, it allows you to construct a manageable differential diagnosis of key common or can't-miss diagnoses. The 5 diagnostic categories we will consider today are ischemic heart disease, community-acquired pneumonia or CAP, pulmonary embolism or PE, musculoskeletal etiologies such as from trauma or costochondritis, and gastroesophageal reflux disease or GERD. The first element of any patient encounter is the history. For any chief complaint of pain, we always want to begin with open-ended questions, such as, "What brings you in today?" or "Tell me about your symptoms." It is during this portion of the interview that you try to glean the cardinal dimensions of the complaint. One useful tool is old cards. As you gather key information using open-ended questions and exploring the cardinal dimensions of the complaint, you will want to begin to formulate a differential diagnosis in your mind. The most important cause of chest pain to keep in mind is ischemic heart disease. Important things to ask about when suspecting ischemia include prior history of MI, coronary artery disease, cardiac risk factors such as hyperlipidemia, hypertension, diabetes, prediabetes, obesity, smoking, lack of physical exercise, poor diet, and stress, exertional symptoms such as pain with walking or pain with exercise, associated symptoms such as nausea, diaphoresis, indigestion, pain that radiates to the left arm, shoulder, or jaw, dizziness, and lightheadedness. Lastly, you want to make sure you ask about any prior cardiac workup, including studies such as EKGs, stress tests, and echocardiograms. Another important cause of chest pain to consider is community-acquired pneumonia. You'll want to ask about the presence of fever, cough, and sputum. You'll want to know if the pain is pleuritic in nature, that is, does it get worse with breathing, and whether the patient has had any recent sick contacts. A frequently missed but deadly cause of chest pain is pulmonary embolism. You'll want to ask about risk factors for thrombosis, such as previous history of a thrombus, recent immobility or surgery, recent travel, hypercoagulative statuses like having cancer. For young women or women of reproductive age in general, you'll want to ask about hormonal birth control. And as a DVT is a usual cause of a PE, you'll want to ask about signs of a deep vein thrombosis, such as unilateral lower extremity edema, erythema, and pain. Another set of reasons for chest pains include musculoskeletal etiologies, that is, pain in the chest wall rather than due to the visceral organs below. Two of the most common causes of musculoskeletal chest pain are trauma and costochondritis. To elicit a history with regard to trauma, you can ask whether the person has injured the area recently or whether they've suffered a fall. When considering costochondritis, questions you might ask are, is it painful to the touch, and does the pain change with movement? The last cause we will be considering today is gastroesophageal reflux disease, or GERD. For this last element of the differential diagnosis, you will want to ask about the classic signs and symptoms of GERD. That is, does the pain intensify when the patient is in the recumbent position? Does it worsen during the postprandial period? And what is the character of the pain? Does it burn? Does it have a bitter or sour taste in the mouth? With your thorough but directed history, you will hopefully be able to move 1 or 2 diagnoses to the top of your differential. Next, we will be discussing the pertinent positive physical exam findings for each diagnosis. Signs of ischemic heart disease may be somewhat indirect. You'll want to begin, as usual, by palpating for the PMI. Whether or not it's displaced may give you an idea of the person's general heart health and heart size. Next, you'll want to listen to the heart for pathological heart sounds. For example, a new onset S4 can be indicative of active ischemia. Remember that an S4 is produced when blood is forced into a non-compliant left ventricle. In the case of active ischemia of the left ventricle, the myocardium is unable to relax. Thus, an S4 may be present. You can remember the sound of an S4 by remembering that it has the same cadence as the word Tennessee, where 10 is the extra heart sound. Let's listen. Tennessee, Tennessee. Another complication of acute ischemia is papillary muscle dysfunction. Remember that the function of the papillary muscle seen here is to maintain tension in the mitral valve to prevent regurgitation during systole. Thus, a new mitral regurgitation murmur may indicate papillary muscle dysfunction, and this may indicate ischemia in a specific location of the heart. To remember the murmur of mitral regurgitation, it is useful to remember that in a normal heart, the mitral valve is open during diastole to allow the ventricle to fill, and closed during systole to allow the ventricle to pump forward. Thus, the murmur of mitral regurgitation takes place during systole and may obscure the first and second heart sounds. It is best heard over the mitral area. Let's listen. If the person has progressed to acute heart failure, other signs of heart failure may be seen. You'll want to examine the neck for signs of increased jugular venous pressure as seen by jugular venous distension. You'll want to listen at the lung basis for crackles. And you'll want to feel if the extremities are cold. If community-acquired pneumonia is on your differential, you'll want to auscultate and percuss and check for tactile fremitus. You will pay special attention to the area of the lung where the chest pain is localized and compare it to the opposing side. When considering pulmonary embolism, the vitals are very important. You're looking for tachycardia, tachypnea, low-grade fever, and hypoxemia. You will want to examine the body for signs of hypoxemia, such as cyanosis of the extremities. You will also want to listen to the heart and lungs. Listen for crackles and a pleural friction rub. Now, let's look for signs of a deep vein thrombosis. You'll want to look for unilateral lower extremity edema. That includes swelling and pitting, as well as unilateral erythema, tenderness, and a palpable cord. To determine whether the chest pain is of musculoskeletal origin, the first thing to do is ask, can you show me where it hurts? You can then press slightly on the area and then more deeply. If the pain is reproducible on palpation, it may be musculoskeletal in nature. Even in cases of tenderness, if the probability for other causes is intermediate or high, you still need to further evaluate those possibilities. Look for bruises or signs of prior trauma. Also palpate at the costochondral junction seen here to evaluate for costochondritis. If this elicits pain, the pain may be musculoskeletal in nature. Lastly, you will want to examine the patient for GERD. If you palpate the epigastrium and this reproduces the pain, right about here, and the pain is of a quality typical of GERD, this would favor GERD as the etiology. We hope that you have found this video useful and enjoyable. We want to reiterate that this is not an exhaustive list of the causes of chest pain, but rather a more manageable group of diagnoses with associated findings on history and physical, around which to frame future encounters with patients. Good luck!